So we've had a surprising number of musical references so far in Soul Schneider, and I feel a little disappointed. I thought I had the novelty here, although I'm probably the ugly sister compared to Dr. Mason and Dr. Zen, because I'm a rock and pop music fan. I'm not quite as sophisticated as those two guys. So you're probably wondering, why are we seeing images here of famous rock stars and pop legends from recent times? Well, I saw inspiration for this talk from medical as well as non-medical sources. And as every rock and pop fan knows, the Bible, which covers information about the top albums of all time, is published on a regular basis by the famous magazine Rolling Stone. Now, this was first published in 2005, and you could argue that the editors of Rolling Stone had a similar tough task that I did to try and determine which studies would make the final cut. So I used a very similar approach to the editors. It took a lot of time and effort. I saw experts within the field of OB anesthesia and outside the field of obstetrics, and I used a specific accounting system in order to determine which studies make the final cut. And watch out, there'll be various images of pop and rock stars throughout the course of the talk. There'll be a prize for everyone that gets them all after the lecture's all finished. So the key topics that we'll cover today will include maternal death, postpartum hemorrhage, and I realize we had a big panel on this morning, but there is a number of aspects related to this that make it a very hot topic with regard to studies from 2011 and 2012. And then last but not least, we'll stick on to home turf and look at some important clinical work related to the nuts and bolts of obstetrical anesthesia. So we'll start off with maternal death. And one of the most important articles that came out in 2011 was this article from the UK. This is the 8th report looking at confidential inquiries into maternal deaths that occurred between 2006 and 2008. So over this 3-year period, there were 261 deaths, and these were reported using very robust systems which included death records and birth registrations. Now, the authors of the report calculated that the maternal mortality rate was just over 11 per 100,000 maternities. So this rate is pretty low, which is very encouraging. And by the way, if you're wondering what a maternity is, this is a pregnancy that resulted in either a live birth or a stillbirth at or after 24 weeks of gestational age. So the rate is very low, and the other encouraging finding here is that it's actually come down compared to the rate in the prior triennium, which was over 13 per 100,000. And the authors speculate that the reason for this is because of improvements in the prevention and treatment of postpartum hemorrhage and complications secondary to preeclampsia. Now on this slide, what I have here is a bar chart looking at the common etiologies for maternal death that occurred over this 3-year period. And if you cast your eyes over to the left-hand side of the graph, you can see that the most common cause of death is that due to cardiac disease. Now, unfortunately, this is nothing new. We've seen this in the prior triennia, and also we've seen this in the most recent mortality data from California as well. So this reminds us that we need to be careful when we're managing these high-risk patients who have inherited or acquired cardiac disease. Now, if you look at the top 3 leading causes of death, these are in fact all medical disease processes that have either been exacerbated by or worsened by pregnancy or the advancing effects of pregnancy. So we need to be careful here when we're dealing with patients and seek help from our obstetrical colleagues as well as our medicine and surgical colleagues as we try and safely navigate these high-risk patients through the antenatal, peripartum, and postpartum periods. The leading obstetrical cause of death was sepsis, and this was a new one for this triennium, and of these, the majority of patients died from ascending genital tract infection, which was due to group A streptococcal disease in the majority of cases. And so there'll probably be a lot more interest coming out in the literature related to this topic in order to identify patients earlier on who have early signs of sepsis, so we can hopefully manage these patients much better and avoid this terrible outcome. Another important article that's looked at maternal mortality came out in 2011, and the authors were led by Joy Hawkins and colleagues from Colorado. And this important article looked at rates of anesthesia-related mortality between 1979 and 2002. So within this time period, they divided up into 2 time epochs, and they found that there was a dramatic reduction in the rate of anesthesia-related maternal mortality when they compared the time epoch between 1979 and 1990 to the epoch between 1991 and 2002. So these rates translate to about a 59% reduction overall in the rates of maternal death due to anesthesia. And the reason why is speculated to be because we've seen improvements in anesthetic techniques, equipment, and devices that we use to safely manage patients during the peripartum period with regard to regional or general anesthesia. They also calculated the rate ratio, which compared the numbers that died due to general anesthesia to the numbers that died, due to general anesthesia to the numbers that died due to regional anesthesia. And you can see here this rate ratio is pretty low, which implies that the devices and the techniques that we use for managing patients that require general anesthesia have also improved compared to prior time periods. Now, what were the most common etiologies for death for those that died due to general anesthesia and those that died due to regional anesthesia? Well, the most common etiology for general anesthesia was due to either an intubation failure or an induction problem. So essentially what this suggests is that we need to be careful when we're managing patients, again, with high-risk conditions that may decompensate at or after the time of induction. And secondly, and it's a fairly obvious one, be careful when we're managing patients that have non-reassuring airways, or perhaps more importantly, when we're dealing with an unanticipated difficult intubation. In terms of the deaths or the etiologies for those that died due to regional anesthesia, these were more heterogeneous and included high spinal epidural anesthesia, respiratory failure, and drug reaction, which essentially was coded as local anesthetic toxicity. So what this suggests is that we should be careful about the technique that we choose when we're performing a regional anesthetic for either labor analgesia or cesarean delivery, and also be careful about the dose and the drug that you put into the regional technique when you're performing these procedures. Now, on the topic of airway management, do we know any information about patients who may be at risk of a failed intubation? Well, this is an article that came out in 2013. However, it did make the cut because it was published ahead of print in 2012. So these authors were interested in looking at risk factors for failed intubation in obstetrics. So they performed an observational study, and they pulled data from a robust system over a 3-year period in the UK. So they looked at data between 2006 and 2008. So they identified 57 cases of women that had a failed intubation during the course of a rapid sequence induction. So these are all pregnant patients. And they compared these to a cohort who were controls. So they had successful intubations under a RSI. And what they found was that these 3 factors were significantly associated with an increased risk of failed intubation. So an increase in maternal age. So for every 1-year increase in age, the risk increased 7%. For every 1 unit increase in BMI, the risk increased 6%. And if they had a non-reassuring airway assessed as a Mallampati score greater than 1, then the risk was also increased. So you're probably not surprised by the fact that if you're dealing with a patient who is morbidly obese, who's got a non-reassuring airway, that they're an increased risk. Okay, I guess we would all probably have suspected that. But the fact that maybe patients who are of advanced maternal age may be at increased risk is a novel finding. And what we need to do here is probably investigate this in prospective research. The other interesting finding from this study is the fact that for cases where they dealt with a failed intubation, the vast majority were salvaged with a supraglottic device. So this is really reassuring because this indicates that anesthesiologists or anesthesia providers are quite happy and comfortable using a supraglottic device, and most of the times it was a laryngeal mask airway, for rescuing the airway after a failed intubation. So remember, it's not failure to intubate that kills patients, it's failure to oxygenate and ventilate. So the fact that we're reaching for an LMA when we're dealing with these cases is obviously very positive finding. So we'll move on to our next key topic, which is postpartum hemorrhage. And I know we talked about this earlier, but I've tried to save at least one of the most novel findings for this talk. And this was touched upon a little earlier, but I'm going to try and delve a little deeper just for the purposes of the Sam Hughes talk. There was some seminal work that was originally published in 2007 by Charbet that indicated that if you take a fibrinogen during the early phase of bleeding and the fibrinogen level is found to be low, this is strongly predictive of the patients going on to develop severe postpartum hemorrhage. Now remember, with pregnancy, the fibrinogen level normally increases with advancing gestation. And in fact, the normal fibrinogen levels can be anything from between 300 to 500 or even 600 milligrams per deciliter. So just remember that before we move on to the findings from a couple of important papers. The first of which is a paper by COLLOID and colleagues from the UK, which was an observational study looking at over 400 patients with a diagnosis of severe PPH, and they were interested in confirming this relationship between the lowest fibrinogen level and the total estimate for blood loss. And what they found that there was a significant relationship between these two endpoints. So as the fibrinogen level decreases, or the nadir level decreases, the total estimate for blood loss increases. So this relationship was pretty moderately strong overall. The correlation coefficient was about -0.5. So this appeared to substantiate the earlier work. Now, you heard about this study earlier on, so we're just going to examine this again because it's important. This is work by a group in France who have performed an observational study in just over 700 patients, again with a diagnosis of PPH. And this time, they took the fibrinogen level around 2 hours into the course of bleeding. And again, they were looking at the association between this early fibrinogen level and the overall severity of blood loss. Now, what they found was that if they compared a group that had severe postpartum hemorrhage to a group that had a diagnosis of non-severe hemorrhage, the fibrinogen level was significantly less in the severe group. When they performed multivariate modeling, they found that the fibrinogen level between 2 or 3 grams per deciliter, so remember in the US, multiply it by 100, so between 200 and 300 milligrams per liter was about 2. And in fact, if the level is less than 2, it's increased further by a factor of 12. So what this appears to suggest is that if you're managing a patient who has severe bleeding and the bleeding continues after the initial diagnosis, it's probably worth doing a fibrinogen level just to see if it's low, because if it is, you need to be careful about what the overall severity of blood loss might be. Now, we don't know whether this relationship is causative or associative, and obviously keep your eyes peeled for some important work that's coming out to see whether fibrinogen supplementation in those patients that have a low fibrinogen level can improve or reduce the severity of bleeding and improve transfusion outcomes after the surgical and anesthetic management is complete. So we'll move on to our home turf, which is obstetrical anesthesia, and we're going to look at a number of studies that hopefully have provided us with some updated or optimized information about how we manage patients who undergo cesarean section and for those patients that unfortunately get a diagnosis of a post-dural puncture headache. Now, there's been some controversy in the past about the merits of using either a low dose or a high dose of Marcaine for patients who require a spinal anesthetic for cesarean section. The advocates for a low dose will argue that we see fewer dose-related side effects if we use a low dose, so a reduced incidence of hypotension, reduced incidence of nausea and vomiting, and maybe a reduced period of motor block after the surgery is finished. So if the patient is able to move their legs much sooner after the section is done, then potentially they're able to leave recovery much sooner as well. However, the advocates of a high dose or a conventional dose, depending upon which group you believe in, will argue that we actually see a better quality of anesthesia for those patients that have a higher dose, albeit at the detriment of these side effects. So what really is the right answer here? Or can we confirm any of these early suspicions? So this is an excellent systematic review that was published by Christian Arzola and colleagues from Canada in the BJA in 2011. And these authors were obviously interested in comparing a low dose to a conventional dose. So based upon data that they pulled from 12 randomized controlled studies, they determined that a low dose was 8 milligrams or less, and a conventional dose was greater than 8 milligrams. So their primary outcomes of interest were looking for evidence of intraoperative analgesic supplementation or the need for conversion to a general anesthetic. So obviously we're looking here for evidence of breakthrough pain related to the dose of the spinal Marcaine that the patients received. So this is what they found, and this graph is a forest plot, and what this forest plot shows is that if you use a conventional dose, abbreviated to CD, then these patients had a reduced risk of requiring analgesic supplementation compared to patients that got a low dose, abbreviated to LD. However, they did find, based upon secondary analysis, that there was a reduced risk of hypotension for those patients that got a low dose, and also a reduced risk of nausea and vomiting for those patients that also got a low dose. Now, bear in mind these secondary outcome measures, they differed in terms of the definitions of hypotension amongst some of the studies that they pulled, and also the definitions of nausea and vomiting also varied a little bit as well. So as a result, there was a bit more heterogeneity for these secondary outcome measures. So what's the take-home message when we look at this type of study? Well, the feeling is that if you're considering using a low dose of spinal marcaine or a dose equal to or less than 8 milligrams, perhaps we should be a little more careful, because obviously there's a potential that the patients may experience more breakthrough pain during the surgery, in which case we should probably consider a catheter-based technique. So, for example, a combined spinal epidural may well be a viable or recommended approach. Now, obviously, there may be other subpopulations that we feel that are more at risk in terms of breakthrough pain. And this population, one of the populations that causes us the great concern, are the morbidly obese population. And there's been some controversy again in the literature about what types of doses for spinal marcaine that we should consider for patients who are morbidly obese, who are candidates for a regional anesthetic if they're scheduled for elective cesarean section. So this was a topic of interest to a number of my colleagues at Stanford, and this is a recommended study that was published in anesthesiology by Brennan Carvalho and colleagues. So they were interested in finding what the optimal doses are that we should consider for these patients. So they looked at 42 morbidly obese patients, and then what they wanted to do is calculate the ED50 and the ED95. So the effective dose in 50% of patients and the effective dose in 95% of patients. So all these patients received heavy marcaine spinally, and they used a dose range of between 5 and 11 milligrams, and all of these patients had a combined spinal epidural. So the reason why is that if we were going to use doses of around 5 or 6, the expectation is that these patients will get breakthrough pain during the surgery, so that by using a CSE with an epidural, you can supplement the epidural to hopefully counter any problems with breakthrough pain. So the primary outcomes of interest were success at induction. So what we mean here is when you test the block, you want a good block bilaterally to pinprick to about T6 or higher. And the second outcome was successful surgical anesthesia, which was based upon whether the patients received supplementation of the epidural or whether the patient had a pain score above about 20 on a VAS score. So what did they find? So the results are extremely interesting. On this graph, we have the probability of perioperative anesthesia success on the y-axis, and we have the dose of spinal marcaine on the x-axis. Now, what they cleverly did was compare the data from the obese population to a historical non-obese population. And the thing that surprised us all was the fact that the ED50 for the morbidly obese group was in fact higher than that calculated for the non-obese group. And similarly, when they calculated the ED95, again, after extrapolation, the ED95 was higher in the morbidly obese group than compared to those who were non-obese. Now, bear in mind, when you look at the confidence intervals, they're fairly wide, so the implication here is that there may well be some important variation in terms of dose response in both groups. The other interesting thing that they did was look at the proportion of patients who had successful anesthetic induction and also successful period of anesthesia under surgery. So induction in red and for the period of perioperative anesthesia in blue. And what you'll note here is that for patients who received doses at the higher end of the dose range, so 9, 10, or 11 milligrams, and you look at the blue, even patients that had doses of around 10 or 11 milligrams, not all of them had 100% successes in terms of perioperative anesthesia. So again, this is sort of further supports the theory that there's probably more dose variation even amongst the morbidly obese group, and as a result, if you're considering a regional anesthetic, again, a catheter-based technique may be a good idea if you're planning a spinal anesthetic. So a combined spinal epidural is probably a better approach than using a single-shot spinal. So we'll move on to a slightly different topic, which is how we deal with epidural top-ups for patients that require intrapartum cesarean section. Now, these are images that are probably very familiar to you all. The image on the left is a patient who's receiving an epidural for labor. The image on the right is a patient whose abdomen is being prepped for a cesarean section. Now, I have to disclose, these are not images that I took from Stanford. I actually pulled these from the net, and we would probably be pretty disgusted at Stanford if we saw a patient like this on the left. She's not wearing a hat. There's no sterile see-through drape over her back, and there's someone in the background whose hands are sort of on the patient's shoulders and delivering germs onto the skin on her back. So that's not from Stanford. And the second one, I don't know whether there's any anesthetic monitoring being used for this patient. If you look closely, it's not entirely clear. I would hope they're about to put it on in their defense, but we don't really know. Okay, so obviously when we're dealing with someone who has an epidural in, it would be nice to know what the ideal cocktail should be if they're planning, if she needs a cesarean section and are planning an epidural top-up. Now, some previous work from our group indicated that at least if you surveyed SOAP members, most SOAP members use 2% lidocaine as their preferred local anesthetic for an epidural top-up. But obviously there's others that feel differently, and some people use chlorprocaine, and a smaller minority use bupivacaine or ropivacaine. So with that being said, what do we think works best? So this was a topic of interest to a number of authors that published an interesting meta-analysis in the BJA, which pulled data from a number of studies looking at patients who had an epidural in for labor who required intrapartum cesarean delivery. So the primary outcomes of interest were looking at the time of onset for surgical anesthesia and also the quality of anesthesia success, which gives you an indicator about the quality of block efficacy. So they compared 3 different cocktails, the first of which was 2% lidocaine plus epinephrine, the second one was 0.75% ropivacaine, and the third one was a group that was either receiving bupivacaine or levobupivacaine. Now, you probably don't use levobupivacaine here in the US, it's not FDA approved, but they do use it more commonly in countries in Europe. And what they found was that the onset time was significantly shorter in those patients that received 2% lidocaine plus epinephrine than either 0.75% ropivacaine or 0.5% bupivacaine or levobupivacaine. What about in terms of the need or the risk for intraoperative supplementation? So what they found overall that there appeared to be no statistically significant differences between the lidocaine group and those patients that received bupivacaine or levobupivacaine. However, those that received ropivacaine had a reduced risk of intraoperative supplementation compared to those that received bupivacaine or levo. And lastly, when they sort of collapsed together, those patients that had lidocaine and epi or ropivacaine, these patients that were at reduced risk compared to those patients that received bupivacaine or levo. So the feeling here is that if you use lidocaine plus epi, it's probably a good idea because the onset time is much quicker, and that's relevant because if you need to do an urgent cesarean section, you don't have to wait quite so long for the block to work before your obstetrical colleagues can start the case. Similarly, you would presume that using lidocaine and epi is probably giving you a pretty good profile overall, but if your providers that are only using 0.5% marcaine, I would probably caution against this, especially if you need to deal with a patient that requires an urgent cesarean section, where unfortunately it may delay at least the time of onset of anesthesia. Now, the important thing to note here is that they didn't study patients that got lidocaine plus epi plus bicarb, and they didn't study patients that got chlorprocaine. Similarly, there was no indication about how the block was assessed or the timing of delivery of any of these top-ups. So obviously we need to do a little more work here on this front. Sorry, there may be a problem with the slides. Okay, there we go. So the second thing we need to perhaps think about is an epidural is not just an epidural top-up, but whether it's going to work or not. Now, we all hate failure, and I would hate to be the guy in this slide. So one of the things that we want to try and do is avoid it. We want to achieve adequate anesthesia success. So are there any markers that we can look for to identify which patients are at risk of failure of an epidural top-up? So this was a topic of interest to a number of authors headed by Melissa Bauer and colleagues. And what they did was, again, another meta-analysis, which was pretty interesting, looking at risk factors for a failed epidural top-up amongst previously published studies that assessed the efficacy of anesthesia among patients that had an epidural for labor who required a top-up for intrapartum cesarean section. So their primary outcomes of interest were failure of the epidural top-up and or conversion to a general anesthetic, presumably for problems with breakthrough pain. So they identified 3 different significant predictors for failed epidural top-up. The first of which was this. So if the patient required more than one analgesic top-up for labor, then these patients were at increased risk of a failed epidural top-up. So what this implies is that there's an issue which may be flagged early in terms of block efficacy if an epidural is already in place and the patient's complaining of labor pain. Secondly, the indication for cesarean section was important. So if the patient required emergency as opposed to urgent cesarean section, then the risk of a failed epidural top-up was increased. And lastly, the person who was managing the anesthetic. So if the person who was managing the anesthetic was a non-specialist as opposed to a specialist in OB anesthesia, then the risk of a failed epidural top-up was increased. So what this appears to suggest is that obviously it's helpful if you're dealing with a patient, if you've got OB anesthesia experience, be vigilant about the patients who are complaining of pain multiple times during the course of labor, and obviously be wary about the urgency for cesarean section. Again, as we saw in the previous meta-analysis, we're not clear about the timing of delivery of the top-ups, and there may be other factors at work here. So even though the authors found no evidence of an increased risk amongst patients who were of increased weight at the time of delivery, we don't know whether BMI may be an important factor. And perhaps what we need to do is more prospective work to standardize the methods that we use to assess the block, and also standardize the methods that we use to deliver the top-up when we're dealing with an epidural for someone that requires an urgent C-section. So we'll move on to our next topic, which again is related to cesarean section, which is regarding the issue of fluid co-loading. Now, as you've heard from Lawrence earlier on in the conference, there's different types of fluid regimes that we can consider when we're dealing with a patient that undergoes a spinal anesthetic for an elective cesarean section. Now, the reason why we're wondering about these different fluid regimes is that what we're trying to do is avoid, so either prevent or reduce the incidence of post-spinal hypotension. And as you can see on the slide, there's different types of fluid that you can use. You can compare CRYSTALLOID to COLLOID, which has been done in the past in terms of preloading. You can also compare the timing of delivery of the fluid. So compare the fluid being given before the spinal, so a preload, to the fluid being initiated at the time of spinal anesthetic, so co-loading. Now, what we don't know until very recently is the value of using either a CRYSTALLOID co-load or a COLLOID co-load. So we know a lot more now as a result of this excellent study by Sarah McDonald and colleagues from UCL in London. They performed a randomized controlled study looking at 60 patients who underwent an elective cesarean section with a spinal anesthetic. So patients were randomized to go into either a co-load group of 1 liter of hydroxyethyl starch or 1 liter of CRYSTALLOID. Now in the UK they use Hartmann solution, which is equivalent to what we use in the US, which is lactated ringers. Now, all these patients had a titrated phenylephrine infusion that was started at the time of the spinal anesthetic. And what their primary outcome of interest was in this study was an assessment of cardiac output. Now, to do this, they measured the cardiac output using something called a suprasternal device, and you can see a very small picture about this device on the slide. This is a non-invasive device that's placed in the suprasternal notch, and using a Doppler signal, it's deriving information about cardiac output based upon flow across the aortic arch. Now, let's have a look at their findings. And what they found was quite surprising, and they found that there was no significant differences between these two groups at any one of the measured time points after the initiation of the spinal anesthetic in terms of cardiac output. When they measured stroke volume, similarly, again, there was no significant differences at any one of these measured time points in terms of stroke volume between the two groups. So what this study appears to suggest is that if you're unsure about the type of fluid you want to use as a co-load, it probably doesn't matter too much whether you're using a CRYSTALLOID or a COLLOID, but the big caveat here is that this only probably applies to patients that are receiving a phenylephrine infusion to hopefully prevent or attenuate hypotension. We're not sure if the same rules apply if we're using phenylephrine as boluses for rescue or for the treatment, so for therapeutic purposes for the treatment of hypotension. So our last key topic is going to be post-dural puncture headache. And okay, again, there's pictures of rock stars. What's he up to? So the picture on this slide is Coldplay. They're a famous band from the UK, and they released in 2002 a famous Grammy award-winning album. The cover art for the album you can see on the slide. Now, for those people who aren't rock fans, the lead singer of Coldplay is a guy called Chris Martin. He's at the front of this group on the slide, and he's married to a very famous American actress called Gwyneth Paltrow. Now, they have several kids who I believe are named after different types of fruit, and I'm sure when they were thinking about what they were going to do in terms of analgesia for the birth plan for their first child, there's no doubt that Chris Martin must have been worried about the epidural, the risk of Gwyneth getting a headache, and obviously the implications about her getting a blood patch, which obviously must have led to him considering naming his album A Rush of Blood to the Head. Okay, so let's get back on track. So an epidural blood patch was first reported by James Gawley in 1960, and as we know, it's become established as the gold standard technique for the treatment of post-dural puncture headache. Nonetheless, there is some variation in terms of the adequacy and the duration of relief, and no doubt this is due to changes or differences in terms of our procedural technique. And the obvious change here, or the obvious difference here with regard to what we do for the procedure is vary in terms of the volume of blood that we inject through the TUI when we're doing a blood patch. Now, this was a topic of interest to a number of very well-established senior authors in the world of OB anesthesia. And this is a fantastic example of how we as OB anesthesia researchers can club together to form high-quality scientific research as part of our global or international community. So this was a multi-center study looking at 121 patients with a diagnosis of post-dural puncture headache. And what they did was they randomized these patients to receive one of 3 different volumes of blood during the course of the injection. So 15, 20, or 30 cc's of blood. Their primary outcome of interest was a composite, so they were interested in looking to see whether patients got complete or partial relief of their headache after the blood patch had been performed. So let's see what they found. And surprisingly, they found, if you look over to the left-hand side of the bar chart, that there was no difference or statistically significant differences in the incidence of either permanent or partial relief of the headache after the blood patch had been performed when you compare all 3 of these groups. But if you look at the middle of the slide, you can see that the incidence of permanent relief was significantly lower in those patients that received 15 cc's as opposed to 20 cc's of blood. They found no statistically significant differences between those that got 20 cc's or 30 cc's of blood. So the feeling here is that using 20 cc's seems like a reasonable approach. But I think it's a little disappointing to note that there's a fairly low incidence of permanent relief amongst all of these groups. So is there anything here that we need to do differently as opposed to just varying the blood volume? The other thing to bear in mind is that not all of these patients receive their allocated volume. So the higher the volume of blood they were supposed to receive, the lower the percentage of patients that actually received the full volume. And this is probably due to the patients experiencing more peri-procedural back pain, which may well be a volume-related effect. Nonetheless, the authors attempted to account for this with intention to treat, and they found very similar findings. So at least as things stand at the moment, using 20 cc seems like a reasonable approach, but one wonders whether we can do a little better in terms of achieving a rate that's higher than 32% in terms of permanent relief. Now, obviously, we all make mistakes. We're only human. And so it is nice if we can try and rectify these mistakes. Now, the person on the left can't rectify his mistake, but Jennifer Lawrence certainly did, and full marks to her. And if you don't know who she is, Google Jennifer Lawrence and the Oscars, and then you'll realize why I put this picture on the slide. Now, remember, when we've caused, if it happens, a dural puncture, we obviously have to deal with 2 problems. The patient is still in pain, and obviously at some point we may have to deal with the patient getting a headache. So the problems are twofold. So God forbid we actually have to, experience a dural puncture, we have to deal with a dilemma. Do we pass a catheter through the needle and use it as a spinal catheter, or do we take the whole thing out and repeat the procedure all over again and repeat the epidural? So this has caused some debate amongst us as OB anesthesiologists about what is the right approach. So this is a very interesting prospective study that was published by Ian Russell and colleagues in the UK, who looked at 97 patients who experienced an accidental dural puncture with an epidural, and they randomized these patients, or they planned to, with patients going into either an allocated spinal catheter group or a repeat epidural procedural group. Their primary outcomes of interest were looking at the incidence of post-dural puncture headache and also the incidence of epidural blood patch. And what they found was quite interesting. They found that there was no statistically significant differences in the incidence of post-dural puncture headache between these groups, or in terms of the incidence of whether the patients received a blood patch. So that's a little surprising, because some of us believe that by putting a spinal catheter in, that maybe some local inflammatory process around the site of dural puncture may have led to a reduced incidence of headache. But that doesn't appear to be reflected in the data from Ian Russell. But what they did find was that those patients that were allocated to go into the spinal catheter group, ultimately there was a significantly lower incidence that received 2 or more repeat procedures, as opposed to those that were in the epidural group, when in fact there was about 40% or so that incurred 2 or more repeat procedures. So even though there may be no difference in terms of the headache rate or the blood patch rate, perhaps there's more technical difficulties if we're planning to repeat the epidural if we've caused a blood patch, and maybe there's a greater possibility of neuraxial injury as a result. So the feeling is that maybe using a spinal catheter might be a slightly better approach. But obviously, this is a secondary outcome measure. We really need to do more work here to truly elucidate whether this is a valid finding or not. So we're going to summarize the key findings from this data that's so far from this 2-year period. Overall, rates of anesthesia-related mortality are improving, but obviously be wary if you're managing a general anesthetic, especially for someone undergoing emergency cesarean section. As we've heard quite a lot this morning, fibrinogen, if found to be low during the early phase of bleeding, is strongly predictive of severe postpartum hemorrhage. What we don't know is if we treat the fibrinogen earlier on, whether this can improve anything in terms of the bleeding and the transfusion outcomes. We hope that that might be the case, but we'll have to wait and see. If you're wondering about the optimal dose of spinal marcaine, be wary for patients who are receiving doses of 8 milligrams or less, because you may have to deal with problems with breakthrough pain during the surgery. And there is variability in terms of dose response with spinal marcaine in patients who are morbidly obese. For patients who require an epidural top-up, lidocaine plus epi probably gives you the quickest anesthetic onset, although it's likely that maybe bicarbonate may be more helpful as well. But for those patients that have a failed epidural top-up, risk factors include multiple requests for epidural top-ups during the course of labor, urgency of cesarean section, and the experience of the anesthesia provider. There's an equivalent effect on cardiac output if you're using a CRYSTALLOID or COLLOID CO-LOAD, but this probably only applies at least to patients who are receiving a phenylephrine infusion. And if you're thinking about an epidural blood patch for someone that unfortunately has incurred a post-dural puncture headache, 20 cc's is probably reasonable. But if you have to deal with a dural puncture, there appears to be no obvious differences in post-dural puncture or blood patch rates when using a spinal catheter or an epidural, but maybe, just maybe, we reduce our risk of neurological injury or potentially prolonged attempts to get the patient comfortable if we use a spinal catheter as opposed to a repeat epidural technique. So I think I've caught up. In fact, hopefully we're ahead of time. For those of you that are in from out of town, if you haven't gone down to Embarcadero and checked out the art project on the Bay Bridge, please do so. It really is fantastic. They light the thing up and the lights flicker all over the place. It's truly a wondrous sight. I thank you very much for your attention, and I think we're going to have some questions now.